Well, good morning, everyone. Welcome to day 4 for some of us, but day 2 of the Kids Brain Health Network 2023 Annual Conference. It is once again great to see all of you. I hate to break up all the conversations that were going on. And you're looking around the room, people making connections, people haven't seen each other, new friends, old friends. There's a tangible excitement in this crowd, and I think that continues from yesterday. Wasn't that a great day? Wasn't that a great day? I mean, we started very strong, and I want to thank Peter Rosenbaum again for launching us in such a fabulous manner to start the day, which continued and then continued into the evening with even more conversation and connections being made at the reception. So today, I think we have another treat for you to start the morning. And I'm going to ask our 3 panelists if they would come up and join me before I start speaking about what we're going to be doing. Thank you. So this morning's plenary session was planned as a panel because, as we have learned and talked about over the last couple of days, none of us accomplished anything alone. We need to collaborate, we need to work across sectors if we want to affect change. And so the theme of this session was, in fact, mobilizing knowledge and changing practice. To do that, we need expertise across sectors, we need different voices, we need to listen to the needs and concerns of everybody in the chain of moving knowledge into practice to affect better outcomes for children and families. But something we also know is that that gap between knowledge creation and knowledge uptake means that we realize that there is a gap between knowledge creation and knowledge uptake, and that means that research innovations frequently do not reach their intended audiences. So in this plenary session, KBHN has invited 3 change leaders from the areas of research, advocacy, and policy, who will bring a multi-sectoral lens to the discussion of what it takes to bridge the gap between knowledge creation and uptake to improve outcomes for children with neurodevelopmental disabilities. We've asked each speaker to open with a brief presentation, and then we'll open it up for questions and discussion with the audience. So our first speaker is Sue Robbins. And Sue has played many roles over her career, including parent caregiver, patient, advocate, healthcare activist, and author. Her writing has been widely published, including in the New York Times, the Globe and Mail, the Canadian Medical Association Journal, the Journal of Family Nursing, the Journal of Pediatric and Child Health, and the Journal of Medical Imaging and Radiation Sciences. Clearly an interdisciplinary individual. She has spoken at dozens of national and international health conferences about patient and family-centered care, and she also facilitates workshops about storytelling with healthcare organizations. So please join me in welcoming Sue Robbins to the podium.
Hello, everybody. Good morning. Let's get myself set up here. Thanks, James, for the introduction. I'm here as a mom this morning. All the family members in the audience know that families are forced to do advocacy work at the bedside, in schools, at the system level, whether we want to or not. Advocates really are people who must speak their truth to power. And I wanted to pause as I opened today to do a shout out to all the self-advocates that are in the audience and also all the family members. And if you're able to put up your hands so we can see who you are. Awesome. Yay. You ladies too. Yes, yes. I want to quote somebody, Julie Drury. I don't know if you know Julie or not. She's from Ottawa. She's very fierce mama bear and certainly a mentor for me. And she refers to us advocates, us mama bears in particular, as being gently fierce. And that is how we try to do our work. Okay, my reason for being is actually in the room. He's over in the corner there. This is my son, Aaron. He's my youngest son. I have 3 kids altogether. Aaron is now 20 years old, and you might recognize from this picture that he has Down syndrome. This picture was taken about 10 years ago at one of his last surgeries at the Children's Hospital in Edmonton, where we're originally from. We're in Vancouver now. I am a very reluctant advocate. I was taught to be a good girl, to stay quiet, to follow rules, to behave myself, not rock the boat, and be a people pleaser. And I think there's probably lots of folks like me in the audience who were taught the same things. I'm also an introvert, and I hate conflict. And advocacy is full of conflict. But I have been forced to step very far out of my comfort zone, and I will do anything for this kid. I didn't practice this enough because I think I'm going to get a bit emotional, but anything for my kid, as you would for your children, to make sure that he lives a rich and full life. And this is in a world where systems and society are very much stacked against him. My older 2 children are now 27 and 30, and I was thinking about how much I had to advocate for them. They're typically developing kids through their school years and up until when they moved out. And compared to Aaron, I'd say I never had to advocate for them. Never, ever, ever. I mean, I got a call from the principal once, and I had to deal with that with my eldest son. But otherwise, compared to Aaron, maybe 0.0001%. Speaking up on behalf of Aaron, with Aaron as he gets older, very much is a part-time job and is something that happens daily for us. We've had to rail against the status quo in institutions that are built to discriminate against our loved ones because progress for disabled people is not coming nearly fast enough. Okay, this is my diagram that I created. I was trying to think of all the different levels where families and self-advocates have to advocate. And this one I did for healthcare, so you can see at the bottom, it says at point of care. If you're talking about the education system, you could put on the bottom the meeting with the principal or IEP meeting, and you could adapt this to any really sector that we need to advocate in. And I wanted to lean on a bit of poetry, since I'm a writer, to explain what my own definition of advocacy is. And it comes from Audre Lorde, who wrote a very famous book called The Cancer Journals that talks a lot about women's health. But Audre says, "And when we speak, we are afraid our words will not be heard nor welcomed. But when we are silent, we are still afraid, so it is better to speak." So for change to happen, we must speak up. It is often a lonely and polarizing work. Many families have come before us to pave the way, but it's also, we feel, families, a great responsibility to pave the way for younger families behind us. Families speak up to avoid medical harm, to ensure our kids have an equitable education, to battle exclusion and promote inclusion, to reduce suffering, to advance medical care, encourage belonging, celebrate the good stuff, and to highlight system burdens and solutions. Where we know from our family life that things are true because of our own experiences and stories, but we are often asked to prove that they are true. And that's where the researchers come in. I can't think of, there's been many, many times when I've had a meeting about Aaron, and I've needed to bring evidence with me. Bringing my story was not enough. It was considered too soft, too anecdotal, I was only an N of 1. So I'm going to share 2 case studies very specifically about advocacy campaigns, but I just wanted to say, in families' everyday life, we have to bring the evidence. So I was thinking about all the times that we had met about Erin, so I had to bring evidence to prove that inclusion is good for all students, not just my son. That, I appreciate you guys understand what I'm talking about. That all behavior is communication. That was a very basic one that I had to teach his teachers a long time ago. That kids with Down syndrome need speech therapy. All kids with Down syndrome. If we're going to be needs-based, there are certain things with certain diagnoses that are needed, and speech therapy is one thing that all kids with Down syndrome need. IQ testing tramples on our kids' dignity. That's something else I had to bring research for so that we could avoid the IQ testing, but we had to ended up needing it, have done in order to get funding in adulthood. You have to get IQ tested. And IQ testing somebody with Down syndrome, to me, seems ludicrous. And also that families need peer support. I used to run a peer support program in Edmonton for new families with Down syndrome, and we had to go present to hospitals and social workers and prove the need for peer support. So research can help with that. Okay, my first case study. 11 years ago, our local children's hospital tried to shut down our Down syndrome medical clinic. My husband, who's also in the room, where are you, Mike? Okay, there he is. You can correct me if I get anything wrong here. My husband and I led a public campaign to reverse this decision. It was called All Kids Deserve Health Services, which seems kind of like a ridiculous name, but that's what we were after, like all children deserve health services. It included a social media campaign, media coverage, and finally culminated in a question in the legislature to the health minister from a member of the opposition party that was friendly to our cause. The decision to close the clinic was ultimately reversed, but this was only because of the public pressure from family advocates who signed petitions, wrote letters, and were brave enough to share their stories on television through the media. This campaign would have been so much easier if we had had evidence that the Down syndrome clinic was improving patient outcomes. All we had, as far as data, was the number of families served by the clinic. What we needed to strengthen our argument was evidence that justified the value of the service. Us families all knew that the nurse coordinator in the clinic had prevented many emergency department visits and even hospital admissions, but we had no hard evidence to back that up. And families had nobody to ask for this data. Our campaign was directed at the provincial government that tried to shut down our clinic, and it was the provincial government that owned the data that could provide the evidence that we needed. So that you can see, us grassroots families, we're in a bit of a pickle. So I'll leave you with this question. Who is going to ask a relevant research question on our behalf? Who is going to fund this research for a bunch of rabble-rousing families? How long would we have to wait for the results we needed for this very timely matter? All us families had were our stories, and thankfully in this case, our stories were enough, and our clinic was left open, and it is actually still open to today. Yay, yes, I know. It was a very intense, it was only a week-long campaign, but it was an extremely intense campaign, and I hope they won't touch that clinic again after that. But we did have to go to the media, and you can think about the emotional burden of families in a panic that they were going to lose their clinic, having to go to the media and share their stories. All right. Okay. Case study number 2 is called Ready for My Shot. This is closer to the day. It was zoomed forward to 2021. Provincial governments were rolling out the COVID vaccines and creating priority lists for the first shots. Anybody who has ever had a loved one in the emergency room struggling to breathe knew that COVID was and still is a dangerous virus for our sons and daughters. For the most part, people with developmental disabilities and intellectual disabilities were excluded from the first initial COVID priority lists, and I'll just say this as an aside. In my province in BC, the folks who worked as servers up in Whistler got their COVID shots before my son with Down syndrome did, And that shows the priority of the government at the time as far as who was important to keep healthy and safe. Anyways, and this will be a bit political. So I was allowed to say, I asked James if I could be provocative, and he said yes. Okay. Yes, so we didn't feel that was right. I didn't want to take away the shots from the servers because, of course, they needed the COVID shots too. But we felt very strongly that our kids needed to be protected from COVID. So case study number 2 is about the Ready for My Shot campaign that began really around a kitchen table in our condo with my husband and I. Included a website, social media, a video, stories from self-advocates, but we, again, desperately needed evidence. All we had was one article that was published in the UK in the late 2020 that found that people with Down syndrome were 10 times as likely to die from COVID. And my son is here, and we've talked about all this. He was very active in the campaign as well. Because it was an article from the UK, it was dismissed outright in Canada. And in fact, sometimes I find if it's not an article from a specific province, it can also get dismissed outright. And I guess my question to you is, why is that? But we had absolutely no Canadian evidence to back up what we knew was true, that our loved ones were at high risk for a bad COVID result. Thankfully, this is a good news story, I was connected to researchers like Dr. Yona Lunsky, and how many people know Yona in the room? I'm sure many folks, yes, from CAMH, who guided us towards emerging evidence, which was often hidden behind paywalls that we couldn't access. Dr. Lunsky published her own article about COVID and people with intellectual and developmental disabilities a few months later in summer 2021 in the Disability and Health Journal. So anybody who knows Yona knows that she is extremely productive, and a few months to do research and get published in Canada is considered lightning speed, I would have to say. I'm sure you agree with that. So finally, it took us a while, but we did end up having our own Canadian evidence. But again, I leave you with this question. Where was the timely Canadian research to support our campaign? There was none, and maybe this is an impossible ask at the beginning of a pandemic, but why does research from other countries continue to get dismissed here in Canada? However, Ready for My Shot did benefit, although we didn't have our own research, from allies in the research world who could find and vet research for us and also take a look at our campaign communications to make sure that we were saying the right things about the research that we had and that we were technically accurate, because we're lay people. We don't understand the research world like you do. So allies are very important. So if you can't actually do the research, how can you, as a researcher, be an ally to families who are doing advocacy work? Okay, and this is a video. I'll intro it a little bit, and my friends at the back are gonna play it for me. So I just wanted to wrap up with this. This is my son Aaron in 2021 asking the health minister a question about COVID vaccines at a BC town hall in early 2021. So if you wanna play it, that would be great.
Disabilities are more vulnerable to COVID-19 than others. So I wanna go now to a recorded question from a young man who lives with Down syndrome.
My name is Aaron Robbins Waddingham. I live in Burnaby. Disabled people need a fixing right now. Older people with Down syndrome can get very sick from COVID-19. Why doesn't a government listen to disabled people and give us a vaccine right now? Do you care about disabled people or not?
Hey, thanks Aaron for your question, and the answer is we do very much. People who live in congregate living, so people who are living in group homes, are getting immunized right now in phase 2, and priority is being given to people with a variety of health conditions, and Dr. Henry can speak to those in detail, including people with developmental disabilities, people in your circumstances, early in phase 3.
I just want Aaron, where's Aaron? Yeah. Aaron, stand up. You should stand up. Yeah. The clip we chose, we figured we should let the health minister answer, but he didn't actually end up answering Aaron's question in the end, so we weren't sure what congregate care meant, and we had to go and look that up. But again, I have more questions and answers, but my main question that I'll leave you with that maybe we could talk about at the panel is it fair that Aaron and us as his family have to stand alone and advocate for his value as a human being? And really that is the crux of all the advocacy work that us families do. And also he's advocating basically for his right to medical services. So I guess we're tired and we need help, and that is my call to action for you. As far as real world needs, which Kids Brain Health very much focuses on, my call to action is that advocates need access to timely research that asks the research questions that are relevant to our current issues. So are you asking research questions that are relevant to families? How can you support families from your current position? How can you make your research easier for us to access and understand and share? And how can you be an ally to us as we go about our own advocacy work, which for us never ever ends? So us families need you, and as Dr. Rosenbaum, which I think I saw him, where is he? Yes, alluded to yesterday, our silos are currently not serving us. They're not serving us, but I think together we are so much stronger, and there will be strength in our unity. So thank you.
So yes, in our conversation when I was chatting with Sue about this panel, and she asked if she could be provocative and challenging, I said, I hope you are. Because there's one thing that a conference like this should do, at least for people like me, it should make me feel uncomfortable. It should make me challenge what I consider to be important, because it's not what I consider to be important that is important. It's what this family and your families need that is important, and that is a message that the Kids Brain Health Network will always listen to. Our second panelist, our second speaker this morning, is Dr. Susanne Benseler. Dr. Benseler is the director of the Alberta Children's Hospital Research Institute, and I'm going to thank you very much for being a major sponsor of this conference. Dr. Benseler is highly regarded for many achievements in medicine, especially related to advances in precision public health for children. She has led several national and international studies for childhood rheumatic and inflammatory diseases, and established an international and interdisciplinary network of investigators for children with inflammatory brain diseases called BrainWorks. Dr. Benseler is also the principal investigator for One Child, Every Child, a Canada First research initiative with a vision for all children to be healthy, empowered, and thriving. Dr. Benseler.
Good morning, everybody, and thank you for having me here. Thank you for allowing us to support the conference. We're very proud of the partnership with all of you. I'm going to share a project that kept me busy for the last 2 years, and many of my friends and partners, and many of them are here in the room, so a huge thank you to all of you. The title of this project is One Child, Every Child. So this is one child in Calgary, born at 23 weeks, and I think many of you know that children at this age will need a lot of medical attention, clearly the best team of care providers around them. But they need a lot more than that. They need families around them, they need a system around them that supports them. The sad statistic is that Alberta has one of the highest rates of preterm birth in the country. And the other sad statistics is that the risk of death for this girl is 5 times higher if she's born to an Indigenous mom in our province. So health has many components that we need to jointly work on. This is a success story, a story that we as researchers like to tell. This little man here is a 6-year-old previously healthy boy who developed the flu. I hope you got your flu shot. So he got the flu, and within hours, his brain started to get inflamed. He was on the ICU in a coma, and the parents were about to lose their child. And in fact, they had lost the 18-year-old sister with the same story many years before. So we have fabulous genetic testing. We figured out what the genetic condition is. This is all work that we're thanking the wonderful Adam Curtin, a friend and collaborator of mine for many, many years. We even have the fanciest of technology, which is called brain-computer interface, to mobilize, the child's brain to help regain function. This is him. It's really one of my favorite movies. Really, this is what matters, right? You can beat your sister in a car crash, and it's really absolutely critically important. I'm not joking. And so he gets back on his feet with his fancy rehab, and even beats his physician in the run down the hallway, and becomes the poster child of the work that we're doing in Calgary. This is a research success story for one child. But this is the reality in Canada. Canada scores 30 out of 38 rich countries around the world in physical and mental health, and these are data taken from the UNICEF report card. So clearly, there's a lot of work we need to do. For us, in One Child, Every Child, and hopefully for all of us together, research is care, and care is research. Partnership is the key to addressing the key questions that children and families face in Canada. Child health and wellness is a whole lot more than genetics and BCI, as much as I love it, obviously, every single day. It's about safety, food security, education, early support for children with needs, vulnerable populations across our country, a lot of work that we have to do together. And one of the key messages that I don't have to tell you, but we actually had to tell our funders over and over again, is that they should invest in child health research as it is life trajectory research. This proposal was the first ever to be funded for child health, believe it or not. So what we had, the president of our university said in his first speech, Suze had the audacity to believe that we should invest in child health research. Quite a testament to the importance. I hope nobody sees this video. So, but the reality is, for sure, we have to invest in child health research. So we brought a team together, and this is a huge shout out to all of you who have supported this application. Big, big, big thank you. To put an application together to what's called the Canada First Research Excellence Fund. This fund is for all of science, and it is there for ambitious objective that will lead to international recognition and help Canadian post-secondary institutions exercise global leadership. Frankly, we wrote exactly what they wanted us to read, but really what we want to make is a difference for children and families in Canada. We went through a super painful process that I'm not going to share with you, but one of the key pieces was, if you want to move the needle for children and families in Canada, the first argument you're going to hear is you're going to start boiling the ocean, because the problem is so big and it's so diverse and there are so many aspects to consider. So what we had to create is a framework. And this framework is grouped into 3 themes. One is called Better Beginning. This is all about mothers and children, maternal child health. And it's the integration of biomedical and social sciences. So please make sure that you see yourself in this. The second one is called Precision Child Health, Caring and Curing. This is about children with diseases in hospitals, in community practices. And the third one is called From Vulnerable to Thriving. This is about neurodiversity and child mental health. And they're not running in isolation. They're there to connect. And they all have identified grand challenges, and these are supported by 6 accelerators. Indigenous Ways of Knowing, EDI, transdisciplinary training, a very large envelope that I'm really hoping many of you will use over the next 7 years. Comprehensive data integration, we just heard about access to data. In partnership with StatsCan and many others, we will make data available for you to be effective advocates. Technology solutions for children and families to overcome health disparities. What's called the Impact Value Knowledge Mobilization Accelerator. And that's a big shout out to Children's Healthcare Canada, who's one of our partners, as is the Inspiring Healthy Futures Network, and I hope you're all going to be there on Friday. One of the key pieces is that we have made a commitment to walking parallel paths with Indigenous scholars. What it means is that there is a independence of Indigenous scholars across the country and beyond that focuses on Indigenous-led projects. And these are just examples of the work that is done by the 5 leaders in this field. So for example, walking alongside youth, Indigenous language revitalization, and community-based research hubs. Really what it aims to do is meaningful involvement of Indigenous communities. And this is one of my favorite pictures. What you're seeing there is the healing garden that was built next to the Children's Hospital in Calgary. And hopefully we will get into this mindset of having many ways of looking at health and wellness for children and families, equally valued across the country. There's also the mandate for meaningful involvement for equity-deserving groups. In fact, this rock star woman there on the left, Bukola Salami, together with Alim Bawani, is leading the development of an EDI action plan, which will hopefully change the way we're doing research. We're recruiting subjects. We're learning about the most appropriate way of sharing knowledge. I'm just giving you a few examples. So this is theme 1, maternal child health, work done by Jennifer Leeson. So I told you about the poor outcomes of Indigenous children and communities. What she's doing is she's partnering with Canadian Indigenous midwives to develop a new model of care to enhance the care for pregnant women in communities and optimize the child health outcomes. This is work done in the precision health space, and this speaks to what Sue was saying. So we had to make a case that if you're investing in child health and kids with medical complexity and chronic disease, that you're actually saving money. So for example, if you were to decrease the number of kids living with medical complexity by 15% by improving their healthcare, investing in their healthcare at an early stage, and investing in their family support, you will be saving $104 billion in this endeavor. So I know it's not of importance for you, but I can tell you for Canada First Research Excellence Funds, saving money and making money was a key argument. So we had to play their game. And this is a big topic, which is from vulnerable to thriving, which I'm hoping you will engage with us, help us, guide us. This is a 7-year grant. We will have catalyst funding every single year, strategic investments every single year, and trainees that you can all access. This is done in partnership across the province, across the country with partners such as Inspiring Healthy Futures, UNICEF, and CIHR. National partnership with all research institutes, all children's hospitals, and Indigenous partnerships across many different institutions. There's also 140 centers around the world. These are leading centers in child health research that have made a commitment to being partners. So the thought here is not we are going to tell others how to do things. Remember, we're 30 out of 38, so we can learn at least from the 29 in front of us, and as well as many others. So this is multi-directional partnership, exchange of trainees, exchange of knowledge. And this is a framework that we had to build around it, looking at operation, research excellence, outcomes like the UNICEF report cards, and innovation. So for us, research is care. We are hoping for your partnership. We're hoping that every child's outcome is the best outcome possible. This is the little girl that I showed you in the first picture. So thank you all for being partners in this transformational cross-sectoral partnership. with hopefully the best outcome for children and families. We're calling it One Child, Every Child. Thank you all.
Thank you, Susan. And the opportunity that you bring and have presented here is one that I think we should all be excited about, and I'm sure there will be lots of people wanting to have a chat. Where am I? Here we go. So our third panelist is Niya Chari. Niya is the Senior Advisor of Policy and Advocacy at Children's Healthcare Canada. Niya is a seasoned health policy leader with over 15 years of experience. You don't look like you have 15 years, but I know you do. 15 years of experience in driving policy development, thought leadership, public engagement, and media outreach. She has worked in healthcare advocacy at the global, federal, provincial, and municipal levels. As a Senior Advisor, Policy and Research at Children's Healthcare Canada, she has led the association's strategic policy and government relations portfolio, enhancing the public profile of pediatric healthcare with the goal of advancing the health and well-being of children and families. Niya, welcome to the podium.
If Sue is a reluctant advocate, I suppose I am a professional advocate. So thank you everyone for being here this morning. My name is Niya Chari, and I'm here today on behalf of Children's Healthcare Canada and the Pediatric Chairs of Canada. So just a little bit about Children's Healthcare Canada for those who may not know. We are a national association representing the full continuum of care and health providers. So that includes membership of 16 children's hospitals across Canada and healthcare providers across the full continuum of care. We also represent the Pediatric Chairs of Canada, which are representing the department heads or chairs of across Canada. So even before the pandemic, there has always existed an urgent need for policy action to improve the physical and mental health of Canada's children and youth. It's no secret to anyone in this room that children's health and well-being in Canada has been declining for over 10 years. While not directly comparable, as Susan mentioned, the UNICEF report cards document a steady decline in Canada's international standing to this end. The COVID-19 pandemic likely served to worsen these rankings, as scores of families have taken stock of the lingering impacts associated with school closures, loss of family income, social isolation, and delays in access to essential medical services, including routine immunization. There is mounting evidence to suggest the physical and mental health of Canada's 8 million children and youth has suffered tremendously. For many, the effects of this pandemic will last a lifetime. We collaborated with polling firm Abacus Research in the fall of 2022 to conduct some polling data. Here's what we learned from Canadian parents. 68% of parents have seen the pandemic worsen their children's mental health. 48% of parents sought out mental health services for their children for the first time as a result of the pandemic. 63% reported a decline in their child's physical health, and the same percentage reported challenges accessing routine healthcare services for their children. We also asked Canadians how the federal government could lessen the impacts of the pandemic on young people. 92% wanted to see the federal government make children central to their recovery plans, including focused investments in children's health and well-being. 82% believed a coordinated national strategy would be a helpful tool to guide collective action to improve children's health. As a national organization deeply invested in strengthening health systems and improving health outcomes for children, Children's Healthcare Canada, along with the Pediatric Chairs of Canada, has identified an opportunity to bring the subject matter expertise of healthcare leaders, healthcare providers, researchers, and family partners to the table to guide solutions-oriented discussions and actions. For those of you who have been engaged in children's health for some time, you will know that policy assessment, development, and analysis is a relatively new space for Children's Healthcare Canada. As the focus of our organization has evolved towards a systems orientation, influencing policies and investments to strengthen these systems has become an important and necessary role for us. A 2015 publication in the British Medical Journal entitled "The Role of Advocacy in Promoting Better Child Health" describes the opportunity and this responsibility well. The author states, "As a vulnerable group in society, children require others to support their voice or advocate on their behalf. This means because differences in health outcomes are generally preventable and are rooted in inequities rather than purely inequalities, children do not have political power or a democratic voice. Without others advocating for children and the systems and structures that serve them, governments often act in their own best interests, which may work against the health and well-being of children." As a community of child health leaders, we know that health and health disparities that children face are often driven by political policies as much as they are by other determinants. We also appreciate the role that all levels of government play building capacity for health systems to meet the evolving and increasingly complex needs of a growing population of children and youth. So if we know politics plays a role in health outcomes, how do we influence policy? Julius Richmond was a professor of health policy at Harvard, but he was also a pediatrician and child development researcher. Richmond describes 3 factors to influence public policy: evidence and subject matter expertise, social strategies, and political will. Unfortunately, hope is not a strategy. Informed by experts like Richmond and others, we have adopted a federal government relations approach that consists of 4 distinct phases. First, identify the public policy goal. These goals must be relevant to the federal government, in other words, within their jurisdiction or their realm of influence. They must also be ideally consistent or aligned with priorities defined within ministerial mandate letters. A quick glance at the mandate letters of the Ministers of Health, Mental Health and Addictions, and Families, Children, and Social Development reminds us that there are a number of priorities defined that are directly relevant to children, including access to safe and effective medications, expanding access to mental health services, developing mental health standards, improving access to critical care services, and expanding access to primary care. There is a lot more than just funding to work with. Second, find partners who share your goals. An aligned community is harder to ignore. Partners could be individual leaders, organizations, or even members of parliament. Children's health is a unique community. We are highly interconnected with many shared interests and overlapping priorities, and we collaborate with one another regularly. This is appealing to decision makers who can avoid dealing with the small p politics that often exist in the actual space, in the adult space. Next, make your case. Identify or develop the evidence base and narrative to support the policy change. This can take the form of peer-reviewed research, health system data, international experience, or public polling, an economic assessment, or otherwise, in our case. Children's Healthcare Canada, we use our members and partners to help us develop this evidence base, and our family partners play an important role in creating the narrative or the case for change. Lastly, act with intention. Create a targeted campaign with clear key messages. Repeat, repeat, and repeat. Activate your partners and stakeholders and make some noise, but do so with respect. Be solutions-oriented and leverage evidence at all times to maintain your credibility. This has been a particularly important tactic for Children's Healthcare Canada and has served to differentiate us from other advocacy organizations and resulting in a reputation as a trusted and credible source. It has truly helped us open doors and co-create solutions that are purpose-built for children. At Children's Healthcare Canada, our advocacy priorities are currently focused on what we refer to as right-sizing children's health systems. Last fall, children's hospitals and community hospitals across the country were stretched to the limit as the result of a fall viral surge, concurrent to shortages of commonly used analgesics for children. This overnight crisis was, in fact, decades in the making, the result of underfunding and cutbacks in children's health systems for many, many years. As you've likely heard, children in this province, and indeed across most jurisdictions, now wait longer for essential health services than many adults. To measurably improve children's health, Children's Healthcare Canada has partnered with the Canadian Pediatric Society, the Canadian Association of Pediatric Nurses, and the Pediatric Chairs of Canada to call on the federal government to lead the development of a children's health strategy. This strategy builds on goals defined within the Inspiring Healthy Futures framework, particularly those within the Accessible and Adaptable Health Systems priority. A pan-Canadian child health strategy would first acknowledge that status quo is not an option. Our health systems are under capacity to meet the needs of an increasingly complex population of children and youth. The strategy would set meaningful and measurable targets in collaboration with provincial and territory governments. Our advocacy efforts also include a focus on securing funding to implement this strategy. In the short term, ensuing provinces and territories leverage the $2 billion announced on February 7th for child health priorities. We are pleased so far to announce that Ontario and Nova Scotia have made early commitments to this end and significantly have invested in children's health. In the long term, we are asking the federal government to establish a funding envelope to enable the provinces to invest in systems transformations required to achieve child health strategy targets. In order to help us champion these issues, Children's Healthcare Canada announced last month that we are hosting a new all-party parliamentary child health caucus. The caucus is comprised of elected officials from each federal party, as well as 2 senators. The caucus is chaired by Senator Rosemary Moody, a well-known pediatrician, as well as the former Parliamentary Secretary to Health, Adam Van Koeverden. In addition to helping us champion policies to improve children's health outcomes, the caucus provides us with the opportunity to build awareness for incredible innovations in children's health and research, and discuss some of the wicked challenges children, youth, and families in Canada are currently facing. To give you some examples of how we are utilizing our advocacy strategies, in 2020, in partnership with CIHR and UNICEF Canada, Children's Healthcare Canada launched Inspiring Healthy Futures. We developed an action framework that identified 5 interlinked priorities, and in 2023, this week actually, we will be relaunching the Inspiring Healthy Futures Summit 2.0, as we call it, which is going to build on the momentum that was built with that $2 billion pledge from the Canadian government to reconvene this Inspiring Healthy Futures community and develop an acceleration agenda that will establish the next set of priorities to shape research, advocacy, community innovation, and system change to create a future fit for children. We've also been building our evidence base. Earlier this year, we launched the first of a series of research reports focused on the costs of waiting for treatment, care, and intervention for children. And so the research series will establish case studies from different areas. Our first was on spinal surgery, and it showed that currently that the wait times in Canada for spinal surgery for children far exceed the recommendations of safe clinical timeframes in several provinces, and that beyond pain and emotional distress, the wait times that lead to delayed surgeries result in increased costs due to disease progression. As well, we also found that the cost of delayed pediatric scoliosis surgery, based on children currently waiting beyond the recommended time frame, will cost the healthcare system $44.6 million and will lead to additional caregiver productivity loss of $1.4 million. Our subsequent upcoming reports will examine the same situation in the autism spectrum disorder and mental health. And this will help us to provide an evidence base to government officials and leaders to showcase what the cost of waiting for children waiting for treatment actually is. We are also constantly looking at methods to amplify our messages. So we have a shared platform for advocacy, research, and knowledge mobilization, also known as SPARK, which is a program that allows us to amplify research, knowledge, and evidence to a wide and diverse audience. We also have SPARK offerings also include our live webinars, podcasts, e-news bulletin, and our impact consultations with our KM knowledge mobilization team for guidance on successful proposals. It's important to remember that you don't need to be an organization to affect change. As individual champions for children, there are lots of ways to use your voice. Participate in media interviews or podcasts, craft and pitch digital or printed op-eds, publish blogs, participate actively in social media, participate in town halls, conferences, or meetings, engage in parliamentary processes, for example, the Standing Committee on Health, on Social Affairs, and Finance, as well as consultations put forth by the government, and meet one-on-one with decision makers. As my time is nearly up, I wanted to wrap up our plenary session by saying that small wins matter. Relationships matter. Sometimes, even often, more often than flashy campaigns. You could generate momentum one conversation at a time. I would love to learn more about your advocacy priorities and how we could join efforts. I'm available after this session for anyone who may want to chat as well. Thank you.
Well, thank you, Niya, and thank you to all the panelists. So we do have time for questions and discussion. I think we do have microphones that can circulate, at least I hope they do. Thanks. So I'm going to start because you all talked about challenges and opportunities. And what struck me listening to you, and actually some of the other conversations I've had, everybody agrees. Well, I'll say nobody will disagree, including the Minister of Health you had. Nobody will disagree that children are important. Yet you all point to where we have failed. So I'm going to start by asking your opinion, each of you. Where do you think? Where is that biggest challenge? Where is that biggest barrier? Why are we failing when we clearly know the value of our children?
Well, I can speak only about my own experience, having a child with Down syndrome. Is he still there? Oh yeah, you are, Aaron. I alluded to it a bit about value and worth, and I feel very strongly that we are not teaching our students, our medical students, our teachers, enough about disability. And I think there's a lot of ableism that comes through in the systems, and that is the reason that we have to fight so hard for basic medical services for our children. And intellectual disability in particular is something that is very much discriminated against. So just to end a little bit, hopefully, I think promoting inclusion and belonging and having our loved ones out in the community is really the counterpart to that. But I'm not sure that in BC, if you have a kid that has an intellectual disability, once they hit high school, they go to, it says they go to the same high school, but they're in a segregated school. It's in an annex, in a classroom that is separate from the rest of the high school. So, I worry about how our leaders of the future who are heading to med school, if they haven't had exposure and get to know and have a relationship with someone who's disabled, how that affects their practice going forward. So I think it has to do with that.
From the research perspective, I think there are two lessons that I've learned over the last 5 years. I'm a pediatrician caring for children with rare diseases. I'm in this role of a research institute director for the past 5 years, and I think motivating for me has always been that we have to do better for the individual child, for the family, and for children and families as a whole. So there are two barriers just crafting this proposal. One is research is a competitive world. So we are competing with each other rather than being each other's resource or partner, because ultimately we're competing around a small pot of funding, which is, I don't think, a great approach, frankly. I think I'm a big team believer. So one of the reasons we crafted this proposal is to say, yes, there's a little bit of competition. We want really great teams in here, but really we want impact, and we want it. Our community, in terms of moving the needle for children from the research perspective, is a competitive one, and I'm not sure that's necessarily the best approach without a bigger picture behind it. And the second thing, which is an even harder lesson, is we wanted money from governments. And there are so many ministries that claim that they're responsible for children, for the left foot and the right foot and the school and social services, and that is a big barrier towards coming up with a unified plan to improving early childhood education, support for pregnant women and with low incomes, and so much more. So I think that on the other hand gives me hope for us as a community of researchers partnered with all of you, with children and families. I think if we can unify, if we can speak with one voice to say we have to move the needle for children and families in Canada, I think that is going to be the transformative element. I don't think we can wait for a top-down thing, as much as I support Children's Healthcare Canada. But I think there is this divide across health is provincial, then there's 50 million ministries that have an opinion. I think if we, as a community of researchers and families, can speak with one voice and say you have to invest in A, B, and C, here's the evidence for it, I think that's how we're going to move things along.
I mean, I can't argue with that, and I won't. But I will say, I think, getting to, from a systems perspective, why aren't children more of a priority? I think it's just because we're so consumed with the adult problems that we sort of think that the kids are all right and that it'll sort itself out, right? If we take care of the adults, then the children will be okay as well. But that's not how it actually works. And so I think there's definitely an issue of a lack of recognition and a lack of acknowledgement and prioritization of children. I think you also touched on a very important part, which is that children and youth are not neatly slotted in anywhere, right? They fall between ministries. They fall between the lack of integration. I mean, there's, education, healthcare, social services. Those are all different departments with different budgets, and they don't always communicate with each other. So we need, I think, a political lens that is looking just at the impacts on children. That's what we need. And we don't have that because, as I said in my presentation, children don't have a voice, they don't vote. And so I think it's incumbent upon us as their advocates to speak on their behalf and to make sure that they are considered. And one of the prime examples I'll give is we have an election that is potentially coming up. We're all sort of thinking about it. It's in the back and it's lingering. How much are we going to talk about children in this upcoming election? That's an opportunity, right? So I think it's really important that we it requires a cultural mind shift and a mind shift that is generated towards what would Canada look like if we generated policies that were based on improving the lives of children. If we started directing our resources towards improving the lives of children and youth, I think the whole vision of our country would change for the better. But it's not happening at the moment because not enough of us are speaking up and saying that needs to happen and that change needs to be happen. And I think part of that is also because there is no short-term win for children, right? You can't produce an outcome immediately. You have to wait years to see the results. And so that doesn't really flow with our current political context and this constant need to election. So I think if change is going to happen, it's going to be because a room full of advocates make it so.
Thank you.
So a theme of this conference, these 4 days, has really been interdisciplinary work and collaboration. The challenge is that takes time and money. And my question to you as panelists, it takes time and money, and it's also a challenge because when you bring in people to collaborate, it's always not the things you always want to hear. It's hard. So my question to the panelists is, who do you think should advocate for that time and money and bring the right people together so that we can collaborate? We're all in our silos. Who's that central person to bring people together? So I'm interested from all three perspectives who you think that is.
So I can begin this answer. So in terms of who is responsible, I think we all are. I don't think it can rest with a single body or a single entity. I can speak on behalf of Children's Healthcare Canada to say, you know, we're leading some advocacy initiatives. KBHN is doing its advocacy initiatives as well. So I think there's a number of players that are doing this work of convening and bringing people together and advocating. I think the challenge, though, is this concept of resource limitation. And I have to say, as someone who is sort of a professional advocate, I've never found funding to actually be a challenge, in so much as that it is more of an excuse, I would say. There is money. Where there is a political will, there is money. We can find money for things. Look at the pandemic, right? We found resources when we needed to. And so we can do that again and again. I don't think the issue is the resource limitations, even though that's often used as a justification. I think that the actual issue is that there isn't that political will. So we need to mobilize, and we need to ensure that our government leaders are understanding what we want, and that we're clear about what we want, and that we see a direction and a vision for the healthcare of Canada. But I think that it's sort of a misnomer or a misunderstanding in terms of resource limitation. I don't think we should talk about a limitation in dollars. I think we should say there is money. If you want to find it, you can. You just need to generate that will to make them want to do this.
Just I'll only speak from the grassroots perspective. I think it's a reframing of, instead of bringing people to your table, it's to go out to the people. Like, that's, if I was going to flip the script entirely, I did patient engagement work with both the Stollery Children's Hospital and BC Children's, and I never sat in my office. I never invited families to sit around a boardroom table. Like, the hospital is the last place people want to come back to if you've had an experience there. I got in my car and I went out to communities. I drove up to Squamish. I went to Abbotsford. I met with families for coffee, for lunch. And this is going to sound very naive, but if you talk about its relationship and it's one person at a time, I think organizing the groups of families and self-advocates and giving them the power, we do this on our own, right, to help us mobilize. I think if you recenter and refocus on the people that you're serving, that will serve to push for the change that you need. That's what I think. I think it's a bottom-up approach, and yes, you have to start with top-down, but, you know, I just, I struggle. I know you said about being respectful when you do advocacy work, and sometimes that feels like behave yourself. And I think as women in particular, we get told to do that. And I wonder if change is really going to happen unless we get our feet in the streets and we get very angry and outraged about how our children are being treated. And I think maybe that's where change is going to come from. So it's more about going out to the people, understanding communities, as opposed to inviting them to collaborate around your boardroom table.
Perhaps a very brief answer. I think the secret is cross-sectoral partnerships. I think we have to get out of perhaps what you're saying. We have to get out of our labs, out of our individual comfort zone, and ask what others are doing, and learn how we can partner across research, across care, across education, across the many community organizations. And I think that's what you are representing here. So the second piece is we have to tell that we're doing this. You know, we're doing a lot of great things, but we have to talk about it. If we don't talk about it, nobody knows, and that's, I think, perhaps a bit of a barrier of our community. We're not great at saying, "Oh, we're the greatest," right? Just not us, but we have to be aware that that's important to talk about.
Annette?
I already had a hand up,
Oh,
sorry.
sorry. Peter.
In the late 1990s, I make two comments. Number one is I haven't heard the name Fraser Mustard mentioned this morning, which is quite astonishing to me, since Fraser was pushing these ideas, at least the interest in children, a very long time ago. The second comment is that in the late 90s, I had the opportunity to go to a conference organized by Dan Offord, which was held at Rideau Hall, and not Romeo Dallaire, the Governor General at the time, his wife was an advocate for children and organized this meeting. And at the meeting, a Swedish colleague named Lagerqvist, pediatrician, proposed the idea that children should have a vote, and that there are various ways that one could imagine doing this. For example, if you have 2 children and they're under 18, then your family has 2 extra votes to represent the views and the needs of children. We have 20% of our population that is not enfranchised, and we're fussing because children don't have a voice. We could solve that in a way that would be revolutionary.
Can I just?
Yep.
I think what you just said resonated with me in a sense that there are lots of very good models out there. There are lots of lessons we can learn from others, and part of the proposal that we had put forward with regards to the global partnership is not to say, oh, we're shining here, but what are other countries doing that is effective, that we can learn from? What are we perhaps doing that others can potentially benefit from? The key thing is have an open mind, listen to what's out there, and try to bring the best pieces to your communities. And the second piece is, wouldn't it be nice if we had something like Children's Health Canada that is not only health care, but really all of health and wellness for children? Perhaps that's something to thrive to, because when you look at what the other countries are doing that are scoring high, there is a degree of integration at the government level, at the institutional level. I think there is a piece that we're clearly missing, but perhaps we can get there. But the key thing that you are saying is there are people out there that have thought about it. There are other countries that give us models. There are things that we do well between provinces. It's time for us to learn.
Yeah. Annette.
So I think what I'm hearing, and what I really think is the path forward, is first of all to have the partnerships of excellent leaders like the ones at the table at the front, and having families, researchers, and professional advocates working together, because we each bring different perspectives that all help to build the case. So having said that, do we tackle it federally with the hopes that it has a trickle effect to each of the provinces, each with their own healthcare drama? Or do we go to each province, each one with making our case and have some wins across some of the provinces? So I'm curious to know what your thoughts are about this federal versus provincial approach.
Thank you for that question. I think you've struck on one of the most critical pieces of discussing healthcare in Canada, right, is that federal-provincial jurisdiction. So, which I touched on a little bit, but I think we don't have time to just go with one government. I think we need to do both, really, right? So I know our organization is trying to convene discussions at that provincial level, but also at that federal level, because the honest truth is that they both have a role in delivering healthcare for Canadians. The federal government has certain populations that they oversee, and in addition to funding. And we've seen the federal government starting to take more and more of a role in terms of national healthcare with rolling out a dental plan, rolling out pharmacare, things like that. So there is a role for both of them, and I think, you know, they have regular meetings, the FTP meetings, which are the federal, territorial, and provincial meetings, so where they meet. The ministers of health meet, ministers of each department meet. So I think there are opportunities to, it's difficult for advocates on the outside to influence those agendas, but there are opportunities to do that, and I think we have to target both, because we cannot have a federal strategy that is not being implemented in the provinces. And we can't have the provinces doing things without sort of national coordination, because we know that that leads to a lot of inequity and disparity. So I think if we want a healthcare system that is oriented towards children and youth and better outcomes for them, we need to be working with both the federal government, pushing them, and the provincial governments. I know it's a lot of work. As someone who's been a professional advocate for a long time, it is quite laborious, but it is very, very important, and I think that's the only way. It needs to be everybody in this together, and we need to be pushing them to do so.
Annette, this is a really great question, but I really think we have an opportunity as networks, especially networks like yours, like Kids Brain Health. Networks can bring people together that are not necessarily all doing the same thing. And I think one of the strengths in Canada are those networks, cross-sectoral, interdisciplinary. We have to ask ourselves, what is the limitation of our network? To what extent do we bring schools in? Do we community organizations? All of those. But that's our strength. And I think ultimately, we shouldn't wait for a change to happen. We have to drive change.
Yes. So what the issue you brought up reminded me of one of my own experiences when the province of Ontario was considering support for families raising kids with fetal spectrum disorder. There were a number of us who were advising them. And one of the things I told them at that time was that other jurisdictions in Canada had done great work in this area, and there was so much you could learn and shortcut the entire process. And I was told quite bluntly, yeah, we want a Made in Ontario solution. So there was a barrier right there at the provincial government level, preventing them from using, even acknowledging, that somewhere else in the country somebody had already examined this issue and come up with answers that were effective. So that duplication of effort is so wasteful of time and resources when we could actually come together. And I think it is incumbent on us as a network of multiple sectors, multiple voices, to push that agenda of collaboration to achieve the greater good for everyone. Where am I going?
Here first.
Okay.
I realize that I may be being a little bit deliberately provocative and a bit of a heretic in this audience, but with the recognition that all children have differing abilities than adults, would it not be more productive if we focused on a strategy for mixed abilities of all Canadians that would quite obviously or frankly include a lifespan approach as opposed to singling out children?
I think, yeah, Dr. Rosenbaum talked about lifespan, and that's come up quite a bit. I always say about, my son is now 20, so he just went through the transition, which I call growing up. Like, I mean, he grew up just like my other two kids. But again, it's because of the different ministries are responsible for kids versus adults, and it's like an artificial construct. That's not what happens in real life. Your kid just suddenly turns 18, and then you have to deal with starting all over again with everything. And, you know, I'm not sure we can change the way the system is put together, but one thing I do agree with is, especially with families who have kids who have different disabilities, there's a real scarcity model that they make us fight for funding between us, and that's what keeps us weak. That keeps us and that's done on purpose. That's done on purpose to keep us weak. It's like we have civil war between autism and Down syndrome and CP, and the fact is, all of us families have so much more in common than our different diagnoses, because we deal, when you talk about burden, the burden is not my son. The burden is systems and society. So, yeah, I'll say that. Make sure Erin hears that. That's very, very important. And I just think, you know, I do a lot of patient engagement work, and I talk about working with clinicians. And, you know, if you could just add the word together to anything you're talking about, we could add the word together and really think about, and I wanted to make sure that I said this, you talk about family leaders, do not just engage people like me. So I am a white middle-class woman who has the ability to come to a conference like this. And, you know, you talk about diversity all the time. I've been going to the old CAFC conferences like from 20 years ago, and they're still talking about that. The only way you're going to engage folks who are not just like you is to go out into the community and talk to people. So really thinking about how we're coming together, I think, to collaborate is important. And as I said, going out to the people is key, not inviting them to the boardroom table. Otherwise, you're just going to get my perspective, which maybe validates your perspective, but that's not where the learning is.
And if I can just touch on that too, I don't disagree with the lifespan approach. Unfortunately, that's not always how decision-making operates, but I think the problem and the challenge that we have is that if we don't specifically ask for a child health strategy or a child healthcare strategy, it won't happen, right? Because when we know that through many, many years, when decisions and policy making is happening, children and youth are left out. And so if there isn't that explicit focus and prioritization, the concern is that their needs will never be addressed. We'll never get to addressing their needs. So I think that's why we are very focused on pushing for child-specific strategy, because countries, as Susan mentioned, countries that have child health strategies are the ones that are doing the best in terms of child well-being outcomes. And so without that strategy, without that focus and prioritization, I just don't think it will happen.
So, Nancy, last question.
Thank you. Oh, thanks. Just one thing I think we should remember is that for certain disabilities and issues, it's much harder for families to advocate. So I'm here as a family member, but also working in FASD and AFCA, Aggression Toward Family and Caregivers in Childhood and Adolescence. So many of us have children who do not want us telling our stories. In fact, for some, it might actually change the trajectory of our child's lives to tell our stories. So that's why I'm personally so grateful to have ongoing collaborations with Kids Brain Health Network, because you've helped us find ways to bring together researchers, professional service providers, and families, and helped us find ways to sometimes tell our stories in a less stigmatizing way. We had 2 amazing families tell stories yesterday in our presentations, but they're really hard to find. They're so brave, but I think we need to realize FASD is more common than autism, but it's much harder for us to collectively share our voices.
Sorry, I just want to add to that. Yeah, when we talk about storytelling, I could do a whole storytelling. We're talking about supporting families. It's not just about standing behind the podium. There are so many other ways. I think that families can tell their stories. I was talking to Ben, is Ben's mom here? I was talking to Ben's mom last night and asking about the best way for Ben to communicate. And Ben is the young man who's made the paintings for the speakers, the gorgeous, he's got a bunch of art out in the concourse. And she said he communicates through art. So if you want to understand Ben's stories and Ben's family stories, then you need to understand his art. And then Christy was talking about digital storytelling yesterday, and sharing a story through film is another way to share stories. So I think we need to blow up the idea of what storytelling looks like, and it's not just, there's only a few privileged people that are able to stand behind the podium, so that we can be more inclusive of all families. So thank you for that.
Well, thank you. Please join me in thanking all of our panelists. Don't go away, because that was a great segue to what I have underneath. We asked each of you your favorite animal, and Ben has painted a picture for each of you that we would like to present to you as a token of our appreciation for your time and your thoughts and your passion and willingness to share with us. So, the lab is for Sue. My lab, yay. And we're going to get a photo, so please stay here. Thank you. So that draws this session to a close. We move into our break from now, and then the next sessions will start promptly at 10:30.